Bismillahirrahmanirrahim. Dr. Shahrukh Nakil is going to present. Uh, I tell people doing small things in a great way is the main aim. So whatever we do, we must do it in a great way. So the first step that we do cataract surgery, this is the first step. Dr. Sharon is going to elaborate.
Assalamu alaikum. My name is Dr. Sharoon, and so we'll be talking about a new biometer that we've recently acquired at our setup and our real-world experience with it. So the topic is optimizing cataract surgery outcomes with swept source biometry. A brief look about the definitions of biometry and a brief history. So, in 75 years ago, Harold Ridley implanted the first IOL, and the patient had a refractive. Oops. The patient had a refractive error of 20 diopters. Yeah, so. Yes, go up a second, please. And from then on, we're on a quest to find some magical formula or machine to achieve emetropia or intended refractive status. Okay, so again, briefly on how we've progressed from contact to non-contact biometry, and we had the ultrasonic biometry, and now we're working on the optical biometry. As the names indicate, the type of light principles used to obtain IOL power in each of these biometries. In context of premium IOL like multifocal toric and EDOF, we'll mainly be concentrating on the optical biometry. So the optical biometry is further of two types. There's partial coherence and low coherence biometries. Okay, this slide briefly it tabulates the differences between the ultrasound and the optical biometry. The main thing is the difference in the ways that it measures the axial length. Ultrasonic is measuring anatomic axial length, and optical biometry gives us the true axial length. Right. So in 1999, the first optical biometer, IOL Master 500, was made commercially available, and it used a wavelength of 780 nanometers. But as we became greedier about outcomes of cataract surgery, we also found problems in this once thought to be a perfect machine. So the shortfalls of this machine included patients with dense cataracts, corneal opacities, subtle macular diseases, poor fixations, vitrectomized eyes. Again, as technology advanced, problems and caveats of the older machine were addressed, and numerous new machines became available, and they all had different principles. The one that we'll be talking about today is the swept source OCT based biometer, and this is what we're currently using in our practice. So IOL Master 700 is the first swept source OCT. It uses 1080 nanometers wavelength infrared light, which allows deeper penetration and more detailed reading. Therefore, it more accurately identifies irregular eye geometrics such as lens tilt. It also images the fovea, so it alerts the observer about poor fixation, subtle foveal macular disease, and all of these things can impair outcomes, particularly in patients who are going for premium IOLs. So this is the layout where you enter the data. It includes a special, I'd like to draw your attention to the vitreous body state, from where, so we can pick either the vitrectomized eye or siliconized eye. And in case of siliconized eye, it calculates true emetropia so that in a couple of months, when the oil is removed, there are no refractive surprises. I would also like to draw your attention to the LVC, the laser vision correction part in the setup. So because of the surge in recent refractive surgeries, we may expect that in the next 10-15 years, most of the cataract patients that we will encounter will have gone some form of corneal refractive surgery, and missing out this point in history or in biometry can result in disastrous post-op surprises, and the machine takes care of that. It reminds you to fill out whatever surgery the patient has undergone. And it calculates accordingly. So these are all the parameters that the machine is going to look at. It gives us 3 B scans for each eye, the first being the corneal thickness, then it looks at the lens thickness, and then the retina. So the top figure in the second column, it's 18 dots that are focused on the cornea, and they give you the anterior keratometry and then the total keratometry. The second image is the white to white. As you all know, that most sophisticated formulas these days use the white to white difference between the two. And finally, the third image is the retinal fixation. Here you can see the dip at the fovea indicating correct fixation to calculate the axial length. So this is an example of where there is poor fixation or not proper fixation at the fovea. The machine alerts you with a dotted red line. Now, the difference between these two images, if you the axial length that it gives you and the IOL power that is calculated, the difference would be almost very minor, about 0.25 to 0.50 diopters. But in a patient, this could mean the difference between a happy and an unhappy patient, again, with these patients who want the best results with premium IOLs. This is a display of all the data that the machine calculates. So it's aligned all the B scans. The first one's the central corneal thickness, the anterior chamber depth, the lens thickness, and then it shows you the retina. Oops. These are all the formulas that the machine's compatible with, and and now a couple of examples from our practice where it saved the day. So this was a 54-year-old female who was a housewife and avid reader, and she wanted to be spectacle-free after the cataract surgery. Multifocal was offered to her after explaining all the risks and complications associated with it, to which she agreed. And she was, during DFE, nothing significant was revealed, and the patient was proceeded to have her biometry done. And during biometry, the machine picks up a very small macular hole, and the whole management plan was changed accordingly. So it saved a potential disastrous ending. And here's another example. So one of the most common causes of a dissatisfied patient after cataract surgery is an early ERM. This patient, a 74-year-old, with a seemingly healthy eye, again, we planned a monofocal IOL, and he underwent biometry. As you can see, the foveal fixation picked up an abnormality, which on the OCT was done, confirmed that it was an early ERM. And if we had proceeded without counseling the patient about probable worsening of the metamorphopsias, as cataract extraction can increase distortion caused by the ERM. So he would have been dissatisfied. And right, so some of the benefits that our setup has experienced because of this machine: it's screened bad candidates for premium IOLs. We've had better post-op refractive surprises were minimized, and it improved efficiency. So it's taking 2,000 scans per second. Both eyes are done in less than 45 seconds. And again, it's largely operator independent. So thank you. Any questions?
The next speaker is Ms. Dr. Noman Hashmani.
So my presentation is on optimizing monovision surgery. So monovision surgery, for those that don't know what it is, it's a technique of doing cataract surgery where you induce myopia in the non-dominant eye and have the dominant eye being emetrope. Before I start my presentation, I would like to invite you. We are having on the January 26th, we're having a big vitreoretinal meeting in Karachi, and there's people from all around the globe coming, and so I would really like to invite everyone to be present there. So our eye is composed of different aberrations. Some are lower order aberrations like myopia and hyperopia, and then there's some higher order aberrations. Together they combine to form the vision that we have, the depth of focus that we have, and you can measure that using various aberrometers like the eye trace that we have. Now, there's different types of aberration that can occur on the cornea and inside the eye, and then they combine to make the total. And it is very important to differentiate between these two, especially if you're doing monovision surgery or if you're doing premium IOL surgery. And then they each have their own contrast sensitivity. And it's very important to know that if the contrast sensitivity loss is there, is it because of the cornea or is it because or something inside the eye? And then obviously the importance of pupil size is very much a big thing, because your depth of focus curves can change, and your the way that you see near far, even in premium IOL practices, extended depth of focus lenses and trifocal lenses are highly dependent on a correct pupil size. So just to start off with, what are depth of focus curves? Depth of focus curves are the traditional ones that we do. They're time consuming, but they can give you sort of an accurate picture of how you're seeing far, and then how that changes to when you come into near and intermediate range. And the results can be variable depending on the technique we use, but we've sort of standardized that technique at our practice because we have this clinical trial unit we've brought in from the States, and it gives us these standardized depth of focus curves. And we're going to use these along with something called a VSOT F, visual strain ratio, based on the optical transfer function that we get on the eye trace. Now, what is the VSOT F? The basic of VSOT F is it uses the Strel ratio. Basically, it uses the ratio of the Strel ratio, and the Strel ratio itself is a ratio of the point spread function of a normal versus an aberrated eye. What is the point spread function? Point spread function is when you pass a ray of lights through a microscope or a telescope or your eye, it creates these small, in a perfectly fine eye, it'll create these small dots of varying degrees, and it'll show you how good that telescope or how good that eye is working based on the aberrations provided. Based on all of this data, the eye trace can then produce something called the VSOT FA curve, which is thought to represent something similar to the depth of focus curve. And the difference is that this takes seconds, and the depth of focus takes several minutes, or 10 to 15 to 30 minutes as well. So how do we use this? The first case that I'm presenting is that we're using an extended depth of extended monofocal lens from the Rayner company. And the advantage of this particular lens is it gives you a little bit of an intermediate vision. And in this particular case, both of these eyes were targeted for plano. So when we targeted this patient for plano, you'll be able to see that when we combine the two, the curves of where that eye can see at what particular distance it can see, they're both overlapping with each other. So this person has a great far vision, but when you look at his near vision, he's not going to have a very good near vision. And that's the point of doing monovision surgery or even doing premium refractive surgery. So then in the case 2, we took a monofocal IOL and we tried to induce monovision surgery. And when we did monovision surgery, we put the dominant eye as plano and then the non-dominant eye as -1.5. Now, when you see this visual strain ratio of both of these eyes combined, now you can see that, let me just turn the marker on. Yeah, so you can see that this particular curve of his right eye, it overlaps with the left eye, but it's overlapping in such a way that there's an elongation of the point of focus of the two eyes, and that's why he can see near and far. Of course, with this technique, you still have to be very careful that his brain has the ability to adapt to this much of a difference. And you would want to put him on contact lenses before you do the surgery. Now, we wanted to replicate this with extended monofocal lenses. So we wanted to see how much of a difference we can actually reduce in these cases, because it's claimed that there is a little bit more of a range of vision in extended monofocal lenses. So the next case we did was a 6-year-old with extended monofocal lenses. Target was plano in the right eye and 0.5 in the left eye. So when we image this 3 months later, the VSOT F curve shows you that we could have probably spread this out a little bit more to get a sort of a better visual outcome for the near vision. And then when we look at the practical depth of focus curves, this is his right eye, which was targeted for plano. This is left eye targeted for 0.5. So there's a little bit of gain that you're getting at the near part. And when you look at the binocular sort of both of them, you get a pretty large part of the eye that's getting a range of vision. And then when we look at his refraction right at the end, his far vision was 20/25 because of the little bit of difference that we introduced. Intermediate was also 20/25, and the near was about 20/40 when we look at both of these eyes. So 2040 would translate to about N10 in this particular case. So what we're learning from this case is that you could probably use extended monofocal lenses. You probably could get away with inducing about -1 in both of these lenses, but it doesn't give you that particular sense of complete freedom from glasses for far and near if you're putting them both on plano. So thank you again. I would like to invite you to the conference that we're doing in January, and thank you. And if there's any questions, I would answer them.
Assalamu alaikum. It's always a pleasure to be here, and I'm going to talk about a skill that every anterior segment surgeon has to have, which is posterior capsular axis. What to do when you have cells or fibers on the posterior capsule that you cannot remove, have a membrane over the posterior capsule. There are certain things that we can do. First, the posterior capsule is not as weak as we think. You can hold it, you can vacuum clean it. If you don't pull, it will never tear. And you can wash the cells, but if they don't wash away, what should you do? If something like this, you see an opacity after you remove the cataract, you see an opacity in the posterior capsule. Here, if you focus well, you can see that many a times there is a membrane on the posterior capsule that you can actually peel off the posterior capsule. And here you can see this is a membrane peeled over the posterior capsule, so you leave the patient with clear posterior capsule. But what if you can't peel it? So you need to do a posterior capsular axis. When would you need to do this? In primary posterior capsular opacity, congenital and pediatric cataracts always, young patients with multifocal intraocular lens implantation as an option, and managing complications as we're going to see. And you must have rules. In any step of the surgery, when you learn it and you know the rules, you understand it, you improve very much, you master the technique fast, and you decrease the possibility of complications. So the idea here that we want to make a continuous tear in the posterior capsule without interrupting the anterior vitreous face. We know there is a space between the posterior capsule and the anterior vitreous face. So you want to do it without the need for anterior vitrectomy or disrupting the anterior vitreous. And this can be done by initiating a tear in the posterior capsule, then injecting viscoelastic, whatever type of viscoelastic, to push away the anterior vitreous face. Then you do your rexis exactly like you do it in anterior capsular axis, and always put a viscoelastic bolus in front of the scratch you made in the posterior capsule to have a support between the viscoelastic bubble behind and in front, so your hand and forceps is the only working force. Let's see example here. This is an opacity in the posterior capsule. You see, you scratch it without piercing the posterior capsule, so you don't interrupt the anterior vitreous face. You inject viscoelastic, create a bubble, pushing away the anterior vitreous face, and then you continue your rexis, and you can control the size according to what you need. This is without disrupting. And then when you implant the lens, always as a rule, inflate different quadrants of the bag, because it is not a continuous bag, and hence it is not like an intact posterior capsule. If you inject in one place, the whole bag will be filled. Here, you inject in different points to open the space, and then implant the intraocular lens carefully into the capsular bag in front of the posterior capsule and behind the anterior capsular axis. Again, even if you have at the end of the surgery narrowing of the pupil, and this is done here in a young patient, so you can do the same technique. If you have the rules, you can repeat it over and over and over. Piercing the posterior capsule, injecting viscoelastic to push away the anterior vitreous face, then doing the rexis and implanting the lens in the capsular bag. And you can see this is a quadrihaptic lens, which you have to be careful while implanting it, but still with a continuous posterior rexis, you can do it easily. Again, This is a patient was planned to have a multifocal lens. He's a young patient. There are some cells. And why we do in young patients, particularly with multifocal lens, a primary posterior capsular access, because in young patients we know the incidence of PCO is high, and so you need to secure a clear visual access. But why not YAG? Some people will say, why not to do YAG? If you do YAG laser, it's an option. But with these types of lenses, if you pit the lens while doing the YAG, this will compromise very much the quality of vision. So if you can confidently do a posterior capsular access without interrupting the anterior vitreous phase, you can reach your aim and give a patient long-lasting, good visual results. It's a repeatable technique that you can use at any time with the same results. This is the most important message I want to tell you. Once you master the technique, then you can use it to recover the complications. Like this case, you can see I'm just washing the posterior capsule, but here the posterior capsule opened. Once the posterior capsule opened, you should decide if there is vitreous, no vitreous. If there is no vitreous, don't invite vitreous. And I want to implant the same lens in the capsular bag. So you stop, you inject viscoelastic, push away the anterior vitreous phase, and convert this elliptical opening or tear in the posterior capsule into a posterior capsular access without interrupting the posterior vitreous, anterior vitreous phase. And in this way, although you have a complication, you can still implant the same type of the lens in the capsular bag, ensuring a clear visual access and a stable intraocular lens where it was placed in the place intended for. So having this skill will help you also to manage complications. And another example, like here, during irrigation aspiration, you can see this bubble, air bubble, obscured the opening. But so I catch the posterior capsule, but with the high magnification, you can identify that there is a problem. You retrieve your hands, injecting viscoelastic, evaluating if there is vitreous, no vitreous, converted into a posterior capsular access, and injecting viscoelastic again to push away the anterior vitreous phase and continue to make a posterior capsular access in a controlled fashion to ensure the ability to implant the lens in the capsular bag. Of course, if you don't do this, you can implant a three-piece lens in the sulcus or to do an optic capture. But if you can do it and implant the lens in the capsular bag, which is the ideal site for an intraocular lens, you should do it once you learn it. So thank you for your attention, and please try to learn this skill because it is very useful, and you're all invited to the Dry Eye and Ocular Surface Society meeting in Luxor next February. Thank you very much. Generally, in young, like congenital cataracts, pediatric cataracts, it's pre-planned from the beginning. And young multifocals, yes, planned. But some cases like mature cataracts, you are surprised with, after you remove the cataract, to have a plaque on the posterior capsule, then you decide intraoperatively. And if you have a complication, again, it's an intraoperative decision. But it's the same principle. Yes, yes. Nothing is never, but actually never. Because if you follow the rules, and these rules strictly, it is 100% repeatedly. And although nothing is 100%, but if you don't make any disturbance in the anterior vitreous, like one mistake is, you saw when I cut the posterior capsule, I used straight needle and I cut it like scratch it like this. I don't pierce it. If you pierce it, you can go into the vitreous. And the younger the patient, the less is the space. So you have to be careful. It's a very repeatable maneuver. Yes, this have a PVD. If they are hot, yes, the PVD I look specifically for it in high myopes. But if a patient had because of the posterior axis, there is not a single report of posterior axis related retinal detachment, but there are reports about cataract surgery inducing cataract retinal detachment, as we all know, and the percentage is less in phacoemulsification compared to extracapsular. And the worry was to increase the incidence of cystoid macular edema. But actually, many studies have shown it doesn't increase. And it was done also in pediatric OCT post-operative after posterior capsular access to check if there is induction of cystoid macular edema or not. And there was not increase in the incidence, which is a very good thing. Mind you that there is an incidence of retinal detachment following YAG capsulotomy, and we can see a lot of reports about this. Yeah. Besides pitting the lens, and if you put a multifocal lens, this distorts the quality of vision very much. Any case, we measure the intraocular pressure. No, I don't use mannitol. I don't use it because unless it is very shallow anterior chamber, there is an indication for mannitol. But posterior capsular access as a procedure does not need any special preparations pre-operative.
I would request Dr. Hashmani to go through a talk given by a German doctor, and the talk was to bag or not to bag. She presented 700 cases where she did anterior capsular access, posterior capsular access, and then she had a special design lenses which will capture both the anterior and posterior capsules. And yes, bag. So, yes. No, but that lady had a huge experience. So we'll keep on talking about it. The next speaker is Dr. Ziaul Mazari. And the next speaker is Dr. Tariq Aziz. So then we have the principal, Professor Ijaz Latif Sir. He will give 3 talks. पहले 2 की भी.
Good evening, ladies and gentlemen. Today we are going to discuss about the automated IEA, and as I've seen some senior professors and most of the juniors doing manual IEA irrigation aspiration with the Simcoe cannula, but nowadays we can shift to the automated IEA, and that's actually very easy and safe technique. Next.
Regarding the vitreous vitrectomy, even if vitrectomy is done in young pediatrics cataracts, you need not do the core vitrectomy. You are just doing, because the AVF acts like a scaffold on which you do the rexes, the ulcerating pearls will grow on top of AVF. So sometimes you will see PCO on the AVF.
Yes, that's correct. It's also below 3 years of age. Sometimes I can, in any 3 years or younger, I will do anterior vitrectomy for the anterior 1/3 of the vitreous. As you say, completely right. Scaffold and that's fine. But the older they get, usually at 6 years, 8 years, I will do posterior capsular access.
We accepted Professor Saab's talk.
At the beginning, I was using cohesive viscoelastic, but actually I found there is no real difference. The idea, don't overinflate. What you need to do, the essence is to push away the anterior vitreous. So usually it's like the size a little bit bigger than the intended posterior axis. So one reason is to push the anterior vitreous face. The second reason because I will inject the same viscoelastic in front of the opening so as to have a sandwich of viscoelastic in front and behind the posterior capsule so you can tear it in a controlled way. Like the anterior axis, if you have a shallow anterior chamber, it will extend. So the same, you don't want this, you want your hand, your forceps is the only acting force. Then you have to neutralize pressure in front and behind the capsule. In this way, injecting viscoelastic pushes away the anterior vitreous face and it gives you support when you inject another viscoelastic in front of the
There is a space of burger. So we must know that there's a gap between the posterior capsule around 3 millimeter, where you can safely do rexes without disturbing AVF. The younger the patient is, the stronger is the AVF. Yes, so even if you are dealing with a subluxated 360-degree subluxated lens, you can do irrigation aspiration to minimize your incision in doing IA of these patients. So the talk of Professor Latif, Ijaz Latif. He has a time for 3 talks. Nothing like it. If you're doing pediatrics, no. The problem of PCO is higher in younger patients as compared to the patient over 50, but still we have very good ways of dealing with the PCO. One. Second is that if you use a lens which is 360-degree covered with the anterior capsule, it inhibits PCO. Third is that the polishing that I need to do. Fourth is that we have a patient who have a primary PCO. The patient who are having a primary PCO, even then you have an option of not to deal with them, because we know that each step that you are going to do is going to produce a trauma. The trauma is at the macula. So I don't want that. When I have made a commitment, we will tell him that during the procedure we found out that you may not get 100% from the results that we have produced today. So in a due course of time, we'll be able to clear your case.
Yes, I agree partly with you, but the idea is that people always fear to deal with the posterior capsule for the fear of vitreous loss and inducing complication. That's why well, the message is you have to learn the technique properly. Because again, the other ways you're talking about doing the dealing with, which is very simple and nice, which is the YAG laser. This is the other way, correct? And YAG laser has an incidence of cystoid macular edema, has an incidence of retinal detachment. It does not mean I don't do YAG. I do a lot of YAG lasers. But I mean, in certain cases, it's better to avoid.
I 100% agree that YAG is a very dangerous tool. It produces a shock wave, and the shock wave is not good for eye. So I would also recommend that the person who has got a lens in the eye of 2, 3, 4, 5, 20 years down the road, and you want to clear his capsule, you do it with 23 gauge cutter.
I think we're going to discuss at length about all of this. If the presentation is not working, we have Dr. Tariq Aziz also. We can have his talk also.
Started working by chance. Exactly. इसी announcement के लिए wait कर रही थी. So let's see what happens now. So it's trying to shift to the automated IA because it's a very easy and safe technique and it's very much time saving. You can learn it within a couple of months or couple of weeks rather. You will become an expert, and the learning curve is very fast and it's time saving. If you do a surgery or particle aspiration with the help of conventional IA or simple IA, then if it takes 1 minute, this will take only 10 seconds. And the important thing is that we don't have to enlarge the side port for the subincial cortex. And there is no regurgitation, and deep AC is formed always, and there's no, the bags remains inflated throughout this. And there is, as it completely seals this, the main port, then there is no regurgitation fluid and the RS can't stick into. Other hand, the second hand is free. When we are doing using Simco, our both hands are busy at the same time in aspiration. But in this case, the other hand is free, and you can use the other instrument with your left hand or non-dominant hand. And it's important that the surgeon's hands, it's very gentle to the surgeon's hands as well. So let's see. It's very easy technique. Just get inside and seal the port with the sleeve. And this is real time. All these videos are real time videos, and you can see how easy it is to take the cortex. See, this is total time which is required. Now, the important thing is that during taking subincial cortex, sometimes we have to enlarge the side port to enter the cannula from the side port. But here you can start directly from the subincial size. You can polish it with the cannula, with the IA tip. You can start from anything. You can go at 6 o'clock and then come to the 12 o'clock, or whatever the way you like. Usually we use with the Simco, we start from the 6 o'clock and sides, and then we come to the most difficult part, that is subincial. But here the subincial is very, very easy. You can start from the subincial or 6 o'clock, anything. And sometimes we have thick layers of the cortex, and with the Simco cannula, at least it will take 1 to 2 minutes to take this cortex out. But with the help of IA, it takes only a few seconds. It's a very thick layer of the cortex.
What about bimanual IA?
Yeah, why to use bimanual when you have got this? At each machine, each and every company supplies this, and we just keep it away. और कभी हमें याद ही नहीं होता कि IA हैंडीज भी साथ आए हुए हैं. Sometimes you think that epinucleus, and see how easily it can take the epinucleus. Sometimes the Simco doesn't take it, but because of the high vacuum, it can very easily take piece of these epinucleus.
Which machine and settings are you using?
I'm using Infinity and AMO.
And it's an option on it to put continue automated the IA.
Yeah, it doesn't take more than 2 seconds of the, maybe 5 seconds of the assistant nurse. So sometimes you find the epinucleus and cortical complex, left thick epinucleus or cortical complex, and
Do you do the anterior capsular polishing?
yeah,
left.
sure. Anterior capsule polishing can be done. Yes, if you like. If you think that there is heavy bulbs.
What is the setting for anterior capsular polishing?
Same setting, but you can reduce the vacuum if you like. Otherwise, you can do it with the same. I have 2 to 3 setting in the IA, but I use only one, and I can polish the anterior capsule, especially in the children, because where I can see thick layers of the Elshing cells.
So there's a specific setting on the machine for polishing itself. It's
So
a very, very
can
low
we discuss
vacuum
it later on? Will you let me finish this first? Now here, I just want to show the nucleus pieces. Pieces of nucleus are there, and you have to take out your cannula at that moment. But here, you can just touch this. See, another piece has come. This is a hard nucleus. Even the hard pieces of the nucleus can be very easily taken. You can just touch with the help of the your non-dominant hand, and you can touch with your dialer or your chopper in the left hand. Simply, you can take it out. So I will see it again. Sorry. Now, sometimes you have got small people, and with IA, Simco is quite difficult. But with this IA, automated IA, you can very easily take, because you can stretch the iris and the pupil. You can stretch the pupil, and you can have a clear view, and you can directly see whether you got cortex here or not. In small people, you should never go blindly, because in Simco you don't have arms. Both your hands are busy with the Simco. But here you can use your one hand to stretch the pupil and see that whether the cortex is directly there or not. And you can also go retro-pseudophagus during the IA for the, to take out the gel from the posterior. And you can see that sometimes it can be pushed in front, but make sure that the edge of the silicon sleeve doesn't push the IOL downwards. So you can easily go behind this and take it out. And where not to go behind the lens. कोई contraindications हैं? There are few only. Torn rexis is an absolute contraindication. उसके पीछे ना जाए. Don't go behind the lens. When the rexis is torn, don't go behind the lens. Or there is suspected PCR. Posterior capsule rent is there, don't go behind this. Or there is subluxation, or you suspect that there is some dehiscence of the zonules, don't go behind this. Or two other indications are very small rexis, because it will be difficult to go enter underneath the margin of the pseudophagus, and a very large rexis. If the rexis is accidentally large size, and you go behind this, the IOL will come out. And we don't need it actually in large rexis. Just press the lens downwards, and all the viscosity will come out, and you can take it out from the anterior surface of the lens. So all in all, this is a very good tool. We are not using in regular basis. इसको जरूर start करें. Last time I saw a live surgery, a very senior surgeon was performing, and he was using Simco. So this is time to shift on it. So you will enjoy it. ये बिल्कुल ऐसी है जैसे ऑटोमेटिक गाड़ियां मैं हमेशा रिकमेंड करता था. मैं बहुत अर्ली मैंने ऑटोमेटिक गाड़ियां खरीदता था, और कोई मेरी बात नहीं सुना कि इसकी वैल्यू नहीं है, इसकी पोस्ट ऑफ वैल्यू. और जिसको मैंने लगाया उस पर, दे आर सो हैप्पी. हमारे ऑप्थेल्मोलॉजिस्ट बहुत से हैं, वो कहते हैं कि यार हम सारी उम्र क्यों ऐसे पाँव मारते हैं क्लच के ऊपर ना. तो ये बिल्कुल ऑटोमेटेड है, बहुत इजी है. इट्स वेरी इजी टेक्निक, वेरी टाइम सेविंग. आपका हर आई एम श्योर हर एक में केस में आपके 2 मिनट कम 1 से 2 मिनट बच सकते हैं. एटलीस्ट 2 मिनट्स आप सेव कर सकते हैं एवरी सर्जरी, बिकॉज यू हैव टू यूज इट ट्वाइस. एक कॉर्टेक्स के लिए
100
और दूसरा
eye hand pieces?
pardon?
Do you have 100 eye hand pieces?
100?
Yes.
No, it's just like the phaco
No,
hand.
if you're doing 100 cataracts, I have 100 Simco cannula. I get new Simco cannula for each patient.
No, ये आपके उसके साथ ही लगते हैं. ये एक्सेसरी है, फेको की एक्सेसरी है. फेको मशीन के साथ आते हैं, सबके साथ आते हैं. आपने जैसे फेको अपनी खत्म की है, न्यूक्लियस को ले लिया है, उसके बाद उसको डिटैच करें और आइए वही ट्यूबिंग आइए कि हैंडपीस के साथ लगेगी, वैसा ही हैंडपीस है. और आप उसको क्विकली करें. पाकिस्तान में अवेलेबल है. अगर आपकी मशीन के साथ नहीं आया या आपने नहीं खरीदा,
We have
तो
another speaker ready.
पाकिस्तान में बहुत अच्छे मिलते हैं, लोकली मेड हैं सियालकोट के, और बहुत अच्छी कंपनियां जो एक्सपोर्ट करती हैं, और बहुत ही थोड़ी सी प्राइस में आपको मिल जाते हैं और बहुत एंजॉय करेंगे। तो मेरे जो 3 सेटअप हैं वो सब मैंने शिफ्ट किए हैं, और मेरे जूनियर भी बहुत एंजॉय कर रहे हैं इसको, ऑनेस्टली।
Thank you very much.
थैंक यू सो मच।
Now, last but not least, Professor Tariq Aziz will talk about a very serious, dreadful problem that we don't want to have, post-operative endophthalmitis.
अस्सलाम वालेकुम एवरीबॉडी। काजी साहब, आपकी इजाज़त हो तो मैं शुरू करूँ, शरारत मत कीजिएगा। डीलिंग विद एंडोप्थल्माइटिस, वी ऑल डू द कैटरेक्ट सर्जरी। एजाज लतीफ़ साहब ने बड़ा अच्छा एलेबोरेट किया, और माशाल्लाह डॉक्टर हाशमानी और उनका बेटा सलमान बैठे हुए हैं, दे ऑल गुड सर्जन्स माशाल्लाह। Complications happens, it happens to everybody. If anybody says कि I don't develop endophthalmitis, वो झूठ बोल रहा है. It means that he's not doing the surgery. Endophthalmitis can happen anywhere in the world to anybody. आप जितनी मर्जी एहतियात कर लें, जितना मर्जी इंट्राक्रैनियल इंजेक्शन लगा लें, and it can happen once or twice in a year. We all face this challenge. तो dealing with endophthalmitis, it's a very sensitive subject. काफ़ी हमारे यहाँ जो है कैम्प सर्जरी होती है, इधर उधर सर्जरी होती है, जब एंडोप्थल्माइटिस होता है तो पीपल ऑलवेज ट्राई टू हाइड इट. सो लेट्स टॉक इट ओपन अबाउट इट कि हाउ टू डील विद इट. नो डाउट it's a most dreaded complication, and when it happens to you, आपको करना क्या है? You know, do not blame the patient. अच्छा तुमने आँख मल ली होगी, you did that, you do that. Don't do that. Don't blame the patient. The patient, post endophthalmitis, it's very rare the patient is blamed. It's your sterilization, it's other issues that matters. So there is no need to blame the patient. Always seek the opinion. Don't be a macho man if you develop endophthalmitis. कि नहीं मैं handle कर लूँगा. Sometimes you cannot handle the endophthalmitis. If you do not handle the situation, the patient go for pillar to post everywhere in the city, और वो आपका नाम रोशन करेगा. ठीक है ना? तो always be polite, be gentle, and seek an opinion from the colleague who are better equipped. आपकी पेरिफेरी में हो, कैम्प सर्जरी करे हो, you're not well equipped. You better refer this patient to a better place. And do not get irritated. We always get irritated. हाँ तुमने आँख मल ली होगी, तुमने कुछ किया होगा, हाँ तुम सुबह जल्दी उठे होगा ना, जब ही हुआ. Don't blame the patient. Don't get irritated. Calm yourself. Hold your horses. Keep all the patient fully informed. If you have developed the infection, if endophthalmitis has happened, tell them. गड़बड़ हो गई है. Don't blame it. Don't blame it. This is a very common practice in this part of the world. हाँ गलती हो गई है, कुछ हुआ है, infection हो गया है. It's a dangerous situation. It's an emergency. And it is better than unrealistic optimism. Refer to the VR surgeon you trust. Look at the word trust. VR surgeon ने अगर कह दिया मरीज के आगे, ओह ये क्या हो गया, वो जो उसने ओह जो किया है ना, that will really take the morale down of the patient. Oh ये क्या हो गया. If you trust the VR surgeon, refer to that institutions. Don't refer if you don't trust the VR surgeon. It will be disaster. The patient will take you to the court, patient take you to the healthcare commission. So be gentle, hold your horses, and tell the referring surgeon, this is endophthalmitis cases I am referring to you. If you wanted to treat the endophthalmitis, please do. AC wash करें, but you max 2 injection you can give intravitreal, not more than 2 injections. If you cannot control it, refer it straight away, and you should examine the patient on the daily basis. Don't be a macho man in this situation. Don't charge the fee. If you have charged the fee, if endophthalmitis has happened and you think that the things are slipping off, refund it. Don't charge it. Don't be an ego issue here. Refund the amount of IOL surgery, and because the VR surgery is going to have it will cost you a lot. Better ask the surgeon, waive it, and you can compensate it later on. Express empathy. Always talk to the patient. We don't talk to the patient if thing goes wrong. This is what, because the court issues are getting higher and higher nowadays. Always talk to the patient. Tell them, उसके कंधे पे हाथ रखो, उसके सर पे हाथ रखो, ये ठीक हो जाएगा. मगर don't give false reassurance. Never ever do that. Understand his or her frustration. Spend time with the patient. ये नहीं कि बात बस प्लीज अच्छा ठीक डॉक्टर ये चलो जल्दी जब ही जाओ कल आ जाना परसों आ जाना. नो, टेक द टाइम. इट्स अ विजन. उसकी आंख है भाई. वो फिर हर जगह आपका झंडा गाड़ेगा पूरे शहर में. प्रोवाइड कंफर्ट, होप, but no false hope. Stay calm. Always stay calm. Give them as much information as possible as far as endophthalmitis is concerned. Look, we are giving you the antibiotics. It may work, it may not work. We are sending you the culture. Uski report aa jayegi. We will look at the sensitivity and then we will manage it. Don't get irritated, as I said. And जिसको भी एंडोप्थेल्माइटिस हो जाएगा वो अपने तमाम रिश्तेदारों को फोन करेगा everywhere. And the relatives might call you in the middle of the night कि सर ये अमेरिका से फोन आ गया, उस वक्त आप सो रहे होंगे. Don't get irritated if somebody call you in the middle of the night कि डॉक्टर साहब वो क्या हुआ, उसके सुना आँख खराब हो गई है. तो आप फोन मत रख दें उसको. Try to handle the situation. It's a vision and it's your reputation which will be tarnished tomorrow. Keep your head cool. Consistency is very important. These are the very questions that they will ask you after the endophthalmitis. How did it happen? Why me? मुझे क्यों हो गया? What to do? अब क्या होगा इसका? What can I do? हमारी आंख तो नहीं निकाली जाएगी. सुना इसके अंदर फिर बाद में पत्थर की आंख लगी, उससे तो नजर नहीं आएगा. These are the questions you have to answer it with a very cool-headed manner. How did it happen? This is the very common thing. Why did it happen to my eye? मेरी माँ को वो ऑपरेशन हुआ था, उसको तो नहीं हुआ था. So what are the chances of visual recovery and pain? Do not give the false reassurance कि हाँ सब ठीक हो जाएगा. Endophthalmitis हो गया है, कभी कुछ ठीक नहीं होता. It's very very rare the patient will get the 6/6 vision. अगर हो गया है तो he will be very very lucky man. Can you remove my eye? It's a very question. मुझे नजर आएगा नहीं आएगा डॉक्टर साहब. So you have to be very very careful. So these are the things that endophthalmitis is rare. It's a rare complication, no doubt, but it's a dreaded outcome. Proper strategy with sensitive management is very, very important. It is possible to emerge with your head held up and without reputation untarnished. So ये सब चीजें हैं. You have to look into that. It's not personal to anything, but these are the tips I thought I should share to you on the cataract forum. क्योंकि ये सबसे ज़्यादा common surgery in this part of the world होती है, and we always face this challenge, but we have to face this challenge with hand up, with sympathy, and to cool down your head. Thank you so much. Thank you, sir. थिएटर के अंदर आप लोगों ने 3 जगह आपने ये स्वैब लेना है. एक तो स्वैब लेना है कि जहाँ पे आप स्टरलाइजेशन करते हैं वहाँ पे कोई लीकेज तो नहीं है. जहाँ पे आप स्क्रब करते हैं वहाँ पे कोई स्वैब नहीं लेता. You must take the swab from the scrubbing room. One thing I wanted to highlight here, ये जो आपने एंडोप्थेल्माइटिस पे जो बुकलेट पब्लिश की है, बराए मेहरबानी इसमें मैसेज ज़्यादा है. लोगों के मैसेज, इसका मैसेज, उसका मैसेज. इसके अंदर कुछ कंटेंट जो है वो मुश्किल से 4-5 पेजेस हैं. उसके अंदर स्वैब्स का कहीं जिक्र नहीं था. We must take the swabs from the where you scrub, and the most important thing जो आपके साथ असिस्टेंट जो हैंडल कर रहा है इंस्ट्रूमेंट्स, he is probably the dirty guy. उसने कभी कभी हैंडल करते हुए खुजा लिया होगा, कभी मल दिया होगा, नहीं बताया आपको. तो your assistant and your technician should be probably told how to do that. Sharif has pointing out this thing very rightly. हमारी मिस्टेक होती है जिसकी वजह से एंडोप्थेल्माइटिस होता है. It's very 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 rare the patient is. Thank you very much, Sharif. I fully induce what Sharif Hashmani is saying here. ये thank you very much. ये पेपर जो था ये बड़ी मुश्किल से ऐड हुआ था इस सेशन में. मैंने इसके लिए बड़ी स्ट्रगल की थी. थैंक यू वेरी मच मजीद साहब. उम्मीद है कि लोगों ने इसको पसंद किया होगा. अगर कोई गलती हो गई तो माफ़ी चाहता हूँ.
Session, and we conclude the session on time.